Hello, I'm Dr. Kenneth Candido from Chicago, advocate, Illinois Masonic Medical Center, and a professor of clinical anesthesia and surgery at the University of Illinois College of Medicine in Chicago. This discussion is about atlanto-occipital and atlanto-axial joint injections. I have no disclosures to make. The atlanto-occipital and atlanto-axial joints are very unique joints in the upper part of the cervical spine. They connect the cervical region to the base of the skull. These joints are often underappreciated as a source of chronic head and neck pain and should be part of a differential diagnosis of anybody presenting with cervical spine pain and occipital headaches. In point of fact, the lateral atlanto-axial joint accounts for about 16% of all occipital headaches. The atlanto-occipital joint shares similar innervation with the AA joint and is responsible for paracervical myofascial pain, bony joint pain, and intra-articular pain in a variety of representations of a referred pain pattern. Injections of these two joints, the atlanto-axial and atlanto-occipital, are used for both diagnostic as well as therapeutic purposes for pain in the deep suboccipital region. The AO joint may be responsible for cervicogenic headaches, occipital neuralgia, and upper cervical pain, which can, in certain cases, lead to an escalation in the prescribing and utilization of opioids. When there's pain with side bending during protraction or retraction, the most likely source of this pain is that due to the atlanto-occipital joint. However, radiological diagnoses of these joints has a very high false negative result, since the onset of pain precedes any observable structural abnormalities. There is a characteristic referred pain pattern for both the AA and AO joint pathology, which overlaps pain and pain patterns from the greater and lesser occipital nerves, as well as from the C2, C3 facet joints, making a clinical diagnosis somewhat difficult. The AA joint primarily refers to the occipital cervical region, where there's pain that radiates to the auricular region, as the AO joint primarily refers to ipsilateral, suboccipital, and retromastoid region pain, although pain may also refer to the paracervical, suprascapular, and levator-scapular regions. The normal atlanto-occipital joint is ellipsoid and permits a passive flexion and a passive extension to about 10 degrees in each denomination, in each location. So it's about a 10-degree rotation, as well as side bending of about 10 degrees. The AA joint articulates with the atlas to the axis and constitutes the C1, C0 joint. That's the atlanto-occipital joint. The atlanto-axial joint is the C1, C2 joint. There is no intervertebral disc at either the AO or AO joint. These are not true zygapophyseal joints, and the nerves that reside here are primarily of a sensory nature with very, very little motor involvement. We find the dorsal root ganglion medial to the AA joint, and the posterior arch of C2 is very deep to the skin and is very difficult to palpate. The transverse processes are long, and we have to reconcile the vertebral artery, which is protected within the foramen transversarium. In fact, there are grooves in C1 at the posterior surface that accommodate the paired vertebral arteries. And the vertebral arteries, of course, need to be understood. The anatomy, of course, needs to be comprehended before undertaking injections of the atlanto-occipital or the atlanto-axial joints. Here are some individual CT renditions as well as fluoroscopic imaging demonstrating the atlanto-axial joints on the left side of the screen, the greater, lesser, and third occipital nerve pathways, and an open mouth view, which is very useful to identify the anatomy of the atlanto-axial and the atlanto-occipital joints. These nerve blocks and these procedures, including pulse radiofrequency, are typically undertaken with the patient in the prone position with a bolster placed beneath the middle of the chest and the head and neck flexed gently forward. This is to open up the anatomy. C1 is also known as the atlas. It's unique. It does not have a ventral vertebral body. And the AO joint is the articulation of the superior articular facet, and the articulates with the atlas at C1 and the occiput and constitutes the C0-C1 joint. The injection into this joint typically holds up to about 1.0 ml of whatever it is we're injecting, whether it's a contrast agent or a local anesthetic or a combination of a local anesthetic with a corticosteroid. Whereas the AA joint, the next joint at C1-C2, typically holds a volume of about 0.7 mLs. The posterior arch of C2 is very deep to the skin. As I stated, it's very difficult to palpate. And we have to, of course, understand the sloping medial to lateral orientation of the vertebral arteries out of the foramen magnum, going medial somewhat to the atlanto-occipital joint and lateral to the atlantoaxial joint, as these figures indicate. The vertebral artery, of course, is a structure which must be avoided because injection of even very tiny amounts of local anesthetic can lead to a grand mal seizure, which can lead to obtundation, respiratory depression, serious morbidity, and even mortality in some selected cases. Pre-procedural considerations include, again, looking at the anatomy with the patient in the prone position and the head and neck flexed forward and with the mouth open view to try to identify the paired atlantoaxial and atlanto-occipital joints. There is a tortuous and sometimes unpredictable pathway and variance between the vertebral artery and the bony structures. Therefore, there is no such thing as a fully reliable and foolproof needle placement for either the AA or the AO joint needle placement, and which is why I always select the central portion of the atlantoaxial or the atlanto-occipital joint before selecting to inject a local anesthetic with or without a corticosteroid. For the equipment for these procedures, I typically use a 22 gauge, 3.5-inch spinal needle of the Quinky type, which has a cutting bevel. I have found that the utilization of more blunt tipped needles, including, for example, a Whitaker needle, is more difficult to gain access into the articulation, and subsequently I use a sharp beveled cutting needle. You also need extension tubing and several different syringes, typically on a smaller volume basis. About 3 mL seems to be sufficient for most cases. Non-ionic, water-based, and soluble contrast is beneficial. A steroid which does not have particles, also known as a soluble steroid, such as betamethasone or dexamethasone, can be added to the injectate. And of course, these blocks can be done using either ultrasound guidance to assist the needle placement and injection, but more frequently, the utilization of C-arm fluoroscopy. And that is because we can identify contrast injected into the joint space compared to what we typically see with ultrasound, which is not a clear identification of the joint space and the contrast injected. The technical steps involve, again, placing the patient in the prone position, maintaining a fully functional intravenous, having resuscitation equipment available, and sedation may or may not be utilized at the discretion of the practitioner. I do not use sedation for the performance of these procedures. There should be a sterile skin prep and drape performed, as for all invasive techniques. And after infiltrating the skin and subcutaneous tissues using a local anesthetic, I put a curve in the distal tip of my 22 gauge, 3.5-inch Quinky cutting spinal needle, and I direct it towards the joint space. In the case of AOAA, I would perform unilateral blocks simultaneously for those two joints, but never bilateral blocks of the AA and AO joints, because this can lead to destabilization of the apparatus, leading to head stability, making patients wobbly, dizzy, and oftentimes unable to walk or ambulate because of the dizziness and instability. Once I make needle contact in the inferior edge of the joint line, I slide the needle without losing contact with the periosteum just off the edge of the bone into the joint capsule. I will often, but not always, appreciate a distinct pop as a needle enters, for example, the atlantoaxial joint, as seen in these renditions. The C-arm is then rotated laterally to assure that the needle has entered the joint space. And once I'm in the joint space, I'll inject small amounts, 0.5 perhaps mLs of a non-ionic contrast agent to determine that there's no spill-off or runoff away from the joint or into an arterial or venous structure. Venous runoff, of course, does not have the dire consequences associated with it that we would see with arterial runoff, but nevertheless should be identified and documented. If there's runoff of contrast into the epidural space, the procedure should be reassessed, the needle should be withdrawn, and a new orientation and direction of the needle should be undertaken. Here's a picture depicting several pictures demonstrating the intraoperative technical steps, including the lateral view of the AA joint, the AP view of the AA joint injection in lateral, and a 3D CT scan reconstruction of successful atlantoaxial joint injections. After confirmation of location and after a negative aspiration, I will inject about 0.5 to 0.7 mLs for my atlantoaxial joint injection and up to 1 ml for atlanto-occipital joint injections. And I typically use a low concentration of bupivacaine hydrochloride solution, about 0.25%. If I'm going to include a corticosteroid, I use dexamethasone sodium phosphate, and I add about 1 to 2 milligrams of that for a total volume, as I stated, of 0.5 to 1.0 mLs, depending on which joint I'm injecting. It also is critically important to continually aspirate and to use extension tubing. Some authorities recommend the use of digital subtraction angiography, but I do not do that. Routinely in my practice, I just perform continual fluoroscopic imaging during the injection phase. Postoperative considerations include avoiding complications and especially arterial injections or air injections, which can cause an embolization phenomenon. For these reasons, I use very tiny aliquots of local anesthetic to decrease the likelihood of cardiovascular or central nervous system toxicity. These joints may share a connection to the epidural space, so it's critically important to assess the patient for runoff or spillover into the epidural space during the performance of these techniques. There are other rare complications potentially associated with these injections, which include infections, post-dural puncture headache, spinal cord or nerve root injury, and of course, ataxia. Ataxia is much more commonly occurring when the procedures are performed bilaterally. Although a 25 gauge needle technique has been described, I don't use it because I find that the 25 gauge needle is too flimsy in comparison to the 22 gauge needle. And I also have identified that the atlanto-occipital joint target is more difficult to reconcile and to navigate into than is the atlanto-axial joint, which seems to have greater ability to accommodate a 22 gauge, 3.5 inch Quincke type spinal needle. I don't do usually local anesthetic block in anticipation of doing my radio frequency procedures, but some authorities would recommend doing that just for diagnostic purposes. When I do radio frequency, I typically do pulse radio frequency at these joints and not thermocoagulation. There are several studies in the peer-reviewed published literature which demonstrate the efficacy and benefits of doing atlantoaxial joint steroid injections in patients with rheumatoid arthritis. This is a publication from Dr. Hedda and Associates in Pain Physician in 2019, where 30 patients received AA joint injection using corticosteroids, in this case triamcinolone, and the other group received systemic steroids. And what the authorities found was that the steroid injection was a potential therapeutic option in that it decreased cervical neck pain, improved neck mobility, and hastened the recovery of the joint from an acute inflammatory stage. And you can see here on this graphic the VAS pain scores and the neck disability index score, which were all enhanced by the performance of AA joint corticosteroid injections. Another paper from the journal Pain Medicine from Dr. Lee and colleagues published recently was describing the effectiveness of intra-articular steroid injections for AO joint pain. And the objective, of course, was to evaluate the role of these intra-articular injections in a group of 24 patients. 20 patients had at least 50% relief of their pain, and they underwent 2 AO joint intra-articular injections using local anesthetic and steroid about a week apart. So for patients with cervicogenic headache, the neck disability index was improved in almost all patients at 1 month, and certainly all the way up to 2 months. And also the VAS score was reduced by more than 50% in those patients who had a substantial benefit. Again, the study was concluded after 8 weeks and showed ongoing benefit for both posterior neck pain as well as for cervicogenic headache. Another study showed the clinical effectiveness of intra-articular pulsed radio frequency compared to intra-articular steroid injections of the AO joint. This was a prospective, randomized, and controlled trial which occurred in 12 patients receiving pulsed radio frequency versus 11 patients who received corticosteroid injections. And in point of fact, these images will demonstrate the actual technique of placing the pulse radio frequency needle and cannula into the joint. of the AO joint, the atlanto-occipital joint. And this shows both before and after injection and the performance of pulse radio frequency. You can see that there was an injection of a local anesthetic mixture, which was lidocaine here with triamcinolone. And in both cases, meaning the steroid injection or the pulse radio frequency, there was an improvement of pain occurring at 1 month and persisting for up to 6 months in the patients who received these modalities, demonstrating that pulse radio frequency is indeed a viable technique in comparison to the injection of corticosteroids and local anesthetic. So there was an equivalency and superimposition of these graphs, both for numeric rating scales as well as for neck disability indices. Here's anatomical considerations for injection of the lateral AA joint. This was published in Pain Medicine in 2019 to look at the AA joint, the C1, C2 joint. And basically it was an anatomical study for determining what the pitfalls were, which might limit the success of these techniques. Here you can see the CT scan reconstruction between the upper cervical vertebrae and the vertebral arteries. Again, the vertebral artery is a critically important structure that must be reconciled in all cases of AO and AA joint injection. So I'll leave this to your edification to read at your leisure, but you can see the intended needle path, the depth of insertion of the needle for the typical procedure, and of course the vertebral artery placement. This is a very important slide from the same article, which demonstrates again the appropriate technique and the avoidance of the foramen transversarium, which is the bony tunnel which houses the bilaterally paired vertebral arteries, understanding how to reconcile this structure and avoid the injection of a local anesthetic or corticosteroid into the artery, which can lead to grand mal seizures and or serious morbidity and sometimes mortality. The proportion frequency of intersection on a per injection basis. This was a large study with 976 injections, showing that there was a theoretical vertebral artery intersection, 1 case per about 70 cases on a per patient basis, assuming bilateral injection, and 1 per 139 cases on a per joint basis, assuming unilateral injection in their cohort. The average distances of the vertebral arteries and the thecal sac from the theoretical trajectory are also indicated here in the graphic on this slide. The mean distance from the ideal needle trajectory to the vertebral artery was about 0.7160 centimeters, and the average total distance from the needle trajectory to the thecal sac, housing the spinal cord, of course, and the spinal CSF was 0.646 centimeters. Important studies to understand. So overall, and in conclusion, the injection of the C1, C2 lateral articulation, if done carefully and correctly, is a safe procedure. Despite good techniques, studies do show the possibility of encountering the tortuous or possibly an anomalous vertebral artery in about 1% of cases. So we must avoid injecting into the spinal canal, the epidural space, or the vertebral artery. And I thank you for your time and attention. And the remaining graphics and videos that I have today demonstrate the actual practical application of atlantoaxial and atlanto-occipital joint injections. Be well.